Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
What is a dental therapist, and have you ever heard of one? If you're like 80% of the dentists I've asked, the answer is probably no. Well, it's a real thing. It's not a hygienist or an EFTA. It's a type of provider that does limited dental procedures and that currently practices in 14 states in the United States, with others on deck to potentially legalize them. So while you may never have heard of this position, it could potentially reshape the profession in the coming decades. So for this week's episode, we're going to look at what a dental therapist is, what they are legally allowed to do, keeping in mind that it varies state to state, where and how they currently practice, and what the future might look like, including how a private dentist could utilize one of these providers as a force multiplier, as well as how corporate could potentially, for lack of a better word, abuse it. My name is Jeff Bloomberg, and I'm your host. And let's kick it off by explaining what this position actually is and what they can do. So what a dental therapist actually is varies state to state, as I said, right? And for example, in one of the states, Minnesota, they have two levels of dental therapists. There's dental therapists and advanced dental therapists. The scope of what they do is preventative, basic preventive care, preventative care, hygiene type procedures, plus basic restorative, cleaning, sealants, fluoride fillings, simple non-surgical extractions, bread and butter, high volume stuff, not implants, not molar endo, not complex surgery, not comprehensive diagnosis and full arch treatment, etc., or treatment planning even. It's a very defined lane. And again, I keep saying this, how they operate and what they can do varies from state to state, right? There's no absolutes, but every state writes its own Dental Practice Act. So what a dental therapist can do in Minnesota isn't identical to what they can do in Arizona. Extractions are a big variable, for example. Some states allow non-surgical extraction of permanent teeth, others only baby teeth. It's not a specific, it really depends on where you are, okay? And as I mentioned, in Minnesota, they have a basic, or they don't call it basic, they have the dental therapist, or a DT, and an advanced dental therapist, or an ADT, the ADT being the upper tier with often a wider scope of what they are allowed to do. Again, you can't hold me to this, but for example, from my recollection, a DT can do, they can extract deciduous teeth, whereas a ADT can do simple extractions on adult teeth, right? So basically, Maine, for example, calls the position a dental hygiene therapist. So basically, there is variables here. Now, how do they practice? So if you're familiar with the concept of supervision, there's direct supervision, and there's indirect supervision, and then there's general supervision, all right? So what's direct supervision? That's where the dentist is in the office, diagnoses treatment, authorizes it, stays, and checks the work before patient leaves. That's direct supervision. Indirect supervision is the dentist is on premises and authorized the treatment, but isn't over the DT's shoulders, so to speak. Whereas with general supervision, the dentist authorized it, but does not have to be in the building when it is done. And that top rung, this general supervision concept, is where I see that sort of the hinge on how we could see a transformation in the coming years, because the dentist doesn't have to be on site in order for the dental therapist in that case to operate, if that's the law in that state. For example, in multiple states, Minnesota, Idaho, Washington, Oregon, for some procedures, Connecticut, under a signed collaborative agreement, the dentist can authorize the work in advance, with the riskier procedures bumped up back the ladder to the dentist, so to speak, and the DT can then do those under general supervision, okay? So now here's where it gets interesting. So you basically have somebody, it's like a very limited dental provider, for lack of a better word, who can do very basic restorative dentistry, depending again on where they practice. But here's where it gets interesting, is the training for the position, all right? So it's roughly a 3-year program. If I'm not mistaken, CODA requires a 27-month program in length, with some prerequisites. In certain cases, if someone has no background in hygiene or no bachelor's degree, it would take longer. It might take 3-4 years. If you have someone who's a hygienist with a bachelor's degree, it might only be 2. The big difference here is you have somebody who, in that short period of time, can do some basic dental type work, and they're not walking out with tons and tons of debt. Whereas when you have a dentist walking out of dental school, they're walking out with anywhere from at the low end $300,000 in debt, sometimes a heck of a lot higher. Whereas the dental therapist isn't walking out with that much debt. Okay. So, in summary, this is what we've got. We've got a trained mid level provider with a defined clinical lane that varies by state, under general supervision in certain cases where there's no dentist required on site. And keep that one in mind as we move forward with this thing. So, now the next issue is okay, we know what it is and we know what they do. Where are they working now? So I went over that there are certain states where they're currently okay to be licensed, but there's a specific requirement in most cases for a dental therapist. So dental therapists, as it stands right now, are authorized in 14 states, and there's roughly another dozen with bills in motion, circling and getting closer in every session. All right. There's about 7 training programs where they can be trained. The dental therapy programs, they exist. I think it's like Alaska, Minnesota, Oregon, Washington, Wisconsin. There's more in development. But usually, the way that this is set up is they are fenced in. They're only allowed to practice in areas that are considered to be underserved. Okay. So, what is an underserved area? It's basically an area that the federal government designates where there is not enough doctors. There's too many patients. The doctor to patient ratio is too high, meaning too many patients. If I'm not mistaken, it's 1 to 5,000 patients. All right. So that's how it's set up. So if you're in an area where there's very few dentists and a lot of people, it's considered underserved. That's an area a dental therapist, if they're licensed to practice in that state, can practice. That's the current fence that's set up. So you're not going to have a dental therapist setting up shop in Manhattan or Los Angeles or Miami or in an urban area because there's enough doctors there. But here's the interesting thing. The reason I'm bringing all of this up, and this isn't to be doom and gloom because that's not my thing, and I don't think it's a doom and gloom type situation. But I want you to consider for a minute. We've all heard of a physician's assistant or even a nurse practitioner. We've probably seen nurse practitioners for primary care if we have bronchitis or something and we get a prescription. Well, that's a newer thing, and I'll get into the specifics on that a little later. That's a newer thing, and when they started out very similar to this, with just a few, and then it was initially, if I'm not mistaken, in underserved areas only, and now you have hundreds of thousands of nurse practitioners and physician's assistants in the United States. So right now, the way where dental therapy stands is there's a fence. There's certain states they're licensed to practice in, but there are certain states where the fence already has a few gaps. Like, I'll give you an example. In Arizona and Michigan, right, they wrote the law without confining therapists to dental safety net only settings, right? So it's a policy choice issue, right? So this could end up in the long term, especially, and this is something to consider, and I went over this in last week's episode. Right now, we're on track where we have been making a lot of dentists. Now, that number is getting better. There are more dental school programs opening. There are more dentists coming out of school, more graduates. But you also have a large portion, and I went over these stats last week, so I'm not going to reinvent the wheel here. There's a large portion of the profession that's in their 55 and over that would be on track to potentially retire over the next 10 to 15 years. So you're going to have a huge exit rate of the I think the word we agreed on was experienced doctors, not older doctors, because I would fit into that category, leaving the profession over the next 10 to 15 years. And the number of new doctors coming in doesn't necessarily fully replenish those numbers. So we're projecting that we're actually going to have less dentists by 2028, a little bit under 200,000. Right now we're at 202. And by 2033, we should be at a surplus again, but really only like 204,000 doctors. The other thing that gets interesting here with this whole dental therapy thing is, remember, they practice in underserved areas. So we know what underserved areas are. It's where the dentist to patient ratio is too out of whack. Well, in last week's episode, I went over this. You can kind of tell I had dental therapists on the mind with the information from last week's episode, but it just didn't make the cut. It would have been too long. It deserved an episode of its own because a lot of people hadn't even heard of this position. But in a rural area versus an urban area, like, I'll give you an example right now, in an urban area, the average patient to dentist ratio is 60. It's in the 60s to 1,000. So for every 1,000 people, there's 60 plus doctors. In the average rural area in the United States, that number is about half, if I'm not mistaken, it was 32 or 33. So in rural areas, you already have areas right now that currently are underserved. So now if you imagine that a large portion of the dental populace or dental practicing dentists are 55 and over, as I went over in last week's episode, and they're going to be retiring, and a lot of those folks own dental practices. It's disproportionate the number of practices and the percentage of ownership the older the profession gets. Like the highest percentage of ownership in dentistry is between the ages of 45 and 54. And 55 to 64 is also very high. Whereas if you go down to the bottom, under 30, uh, again, I don't want to keep bringing up last week, but I went over all this last week. But so listen to last week's episode. But under 30, back in 2005, 25% of doctors owned a practice. That number is now, doctors under 30 is 8.8% that own a practice, and ownership trends are going down. So I want you to imagine this scenario for a second, where you have all these young kids coming out of school. They're not buying practices like they did 20 plus years ago anymore. And the doctors that own the majority of the practices will be retiring over the next 10 to 15 years based on the average retirement age. So you're going to end up with less practice owners. And part of this hypothesis I brought up is over the next 10 years, 36,000 practices are going to change hands. Not all of them are going to sell. Some will be bought by corporate DSOs. Some will be just bought by other practitioners to sort of carry the torch forward. But we estimate that about 17,000 practices over the next 10 years at the current trajectory. Look, anything can change, right? You might end up have a revitalization in people wanting to own practices, which is, I hope. But at the current trajectory, 17,000 practices will disappear over the next 10 years. Say that again, 17,000 practices will disappear over the next 10 years. So they'll either sell their charts to another office or they'll turn in the keys to the landlord. They're just going to stop existing because younger doctors aren't buying. That's what we're projecting. So you see, it's sort of a bit of a perfect storm we have going here. Younger people coming out not buying, experienced dentists retiring and selling or closing their practices. So we already have areas that are underserved, and the rural dentist to patient population versus urban is already way too low. So you're going to end up with these underserved areas becoming even more and more underserved, you see? And that's the thing that sort of opens the door to the dental therapist position. And, I had all these numbers and statistics. I'm not going to do those because I don't think they translate as well on a podcast, maybe on a video. But, for example, there was a bill in the Florida legislature this year to legalize dental therapists in Florida. There are other states that are looking at doing this because there are not enough doctors, because there are areas in the United States which are just packed. The dentist to patient ratio is high. There's a lot of dentists for patients. And you walk down the street and there's an office almost in every street corner. Then you drive out somewhere where there's not, there's people, but there's no dentist out into a rural area. And so like the first piece of advice I would give any young doctor, if they're going, well, where should I operate? Right. Well, I would probably look outside of a major city, because the funny thing is, in the US, you get in a car, with the exception of maybe Miami, you get in a car and you're out in a rural area. And that, if I was a young doc and I was looking at going out on my own, that's where I would practice. I wouldn't buy in an urban area, because I'm not saying you can't be successful there. Some of the most successful clients are in urban areas. That isn't the point, but you're definitely removing some headwinds. There's no competition. There's tons of people. So look, that would be my first piece of advice. If you're a young doctor, you're going, well, what do I do? Move to a rural area. You're going to have no problems there. You're going to find areas where there's, especially these underserved areas, no problems whatsoever. Lots and lots and lots of patients, right? And as a matter of fact, by study, the ADA published this, and I went over this last week, the average revenue in a rural practice is higher than in an urban practice, because there's no doctors. You see, and funnily enough, where do DSOs normally open shop? They don't go to rural areas. They go to urban areas. And by virtue of that, being that a third of fourth-year students say they want to go work for a DSO, where are they practicing them? By virtue of the fact they're working for a DSO, they're working in an urban area. So that'd be my first piece of advice. But I want you to look at how this develops going forward with this dental therapist position. So let's look at how a private practitioner might employ this position if it starts to become, like, let's say you're in a state where it's already approved or is going to be approved. And I would be aware of these things if I were you. But let's say you're in one of those states and you have you see somebody you could hire who's a dental therapist, right? Well, what's the average dental therapist make? Well, that number's kind of hard to get because there's no hard studies on it like on dentists. But from what I can gather, it's about 80 to 100,000 a year. That's the average salary for a dental therapist. And keep in mind, they're not walking around with 3, 4, 500,000 in student debt. They're walking around with tens of thousands of dollars of student debt. They're making 80 to 100 a year. Whereas the average associate doctor walking out of school is walking out with 300,000, 400,000, 500,000, and they're working for 130 to 160,000 a year. So definitely these folks walking out with less debt and maybe a slightly lower income have a bit of a leg up. All right, they have a bit of a leg up. And right now it's a very limited thing, and it's very limited because it's only allowed in underserved areas. Well, that's the fence, so to speak. So as more states approve this and that fence starts to be loosened, you might end up with more of these able to practice, these dental therapists, wherever they want. And it depends on what state you're in. They may be 2 levels, dental therapists and advanced dental therapists like in Minnesota. But let's compare it to the whole nurse practitioner concept. The nurse practitioner role was created back in the 1960s. For years, it's limited, supervised, restricted to filling in gaps where there's shortages because there were doctor shortages, access problems, healthcare costs, etc. So state by state, these walls came down, right? And first 5 states granted full independent practice in 1994. Then Medicare started paying them in 1997. So where does it stand today? I mentioned earlier there's hundreds of thousands. There's over 460,000 in the country, and they have full practice authority, meaning no physician supervision is required at all. And it's the law in 27 states plus DC. So what started as supervised, underserved only became independent everywhere. Okay. So the point I'm making is nobody woke up one day and then all of a sudden, let's change the supervised model. It eroded over time. And what fueled it to a large degree was the fact that there was no doctors or there was no dental availability. If you're a politician and your constituents are telling you there's no dentist here, and then there's a bill in the legislature to approve this dental therapist for underserved areas, we can get them in there. It takes shorter to educate them. They can do rudimentary procedures, and one doctor can supervise 10 of them or whatever. I'm not saying this is the case, but I'm just throwing that out there. Well, then you're going to vote for something like that. So this is something I could see coming down the road. So now let's say you're a private practitioner and you have one of these folks working for you. This could be an incredible force multiplier. They're handling a lot of the basic operative type procedures and simple extractions. They can also do hygienist type stuff, but that frees you up to do a bunch of other things. And it frees you up to do those things at a much lower cost because you're paying this person $80,000 to $100,000 per year as opposed to $120,000, $150,000, $160,000. So that's not bad. I mean, heck, I was talking to one of our clients about this. You could technically have one of these folks as your assistant while you're doing super complex procedures, and you could, you prep the work and whatever. They could make the temps and do the fillings or whatever, and you leave the room, move on to the next patient. It could definitely have utility in a private practice environment, and I think it could actually improve access to care in a private practice environment. But now let's look at the flip side of this. So let's say we end up with rural areas where there's no doctors and, people are looking at a way to solve this. And then you end up with what I call a private public partnership. Okay. So you might have a big DSO and maybe a government agency get together and they're going to work together and they're going to spit some money out from the government to put something there. And then you end up with DSO puts in 10 offices there with a roving doctor who does the more complex procedures. And they have dental therapists in there to, clean up on the simple stuff. And they can make that work even at the lower level of compensation being in network because they're in network with everything because they're not paying the dental therapists as much as associates. Do you follow? I know I kind of explained that very quickly, but that's something I could see coming down the road, in those types of situations. So I think it could be good and it could be bad for private dentistry in that sense. But this sort of brings back to what I was talking about in last week's episode, which is dentistry is more or less developing into 3 tiers, sort of the direction we see it going. Tier 1 will be the independent practitioner. They're at a network. It's not an insurance driven practice. They charge regular fees. There's a big focus on, it's a patient centric practice, right? It's profitable, etc. Then there's tier 2, which will be the DSOs, the private public partnerships. It's heavily insurance based. They may end up developing to the model that I discussed a minute ago, where they can go into a rural area with a bunch of dental therapists. I would not be shocked if you saw something like this happen. And because of the economy of scale with a DSO, they're getting everything cheaper. They can make lower reimbursement being in network work. The problem is tier 3. okay, which is the average doctor in the United States right now, who's 60-70% in network and is collecting anywhere from $600 to $1 million a year. Because what you've seen over the last 5+ years is you've seen a reduction in your income based on reimbursements going down, in the face of also an increase in expenses. So inflation has got up in that same period. I think the number we came up with is we projected that the average doctor has seen a 35% swing, or drop rather, in purchasing power. So if you're in that boat where you're not doing as well as you were 4 or 5 years ago, doing the same thing you were doing because insurance companies are paying you less or whatever, and costs have gone up, they've gone up for everybody. Well, where do you think that's going to go over the next 5-10 years? It's not going to get better. I don't think as insurance companies are going to wake up, the CEO is going to wake up one day and go, gosh, we've been not paying these dentists enough. I just don't see that happening. So what I would be doing in the face of this is a couple of things. Number one, if I was a young doctor and I was looking at picking up a practice, I'd probably go rural because there are going to be a ton available. And it doesn't even matter. There's going to be a ton of practices available over the next 5-10 years. If ownership has ever been on your radar, now is the time. If I was an entrepreneurial dentist and I was thinking about having multiple locations, now's the time. Start looking. This is the time to do it. Now, obviously, you have to know what you're doing. If you're already having trouble in your main practice, that's not a great idea to buy a second one. That's why this works for our clients. This is where I'm flexing, right? Our clients know how to scale. They really do a great job at it, and they know how to scale and keep patient care and improve patient care, make sure it's excellent. So they can pick up that second, third, fourth practice and scale that as well, and they build their own little mini empire. All right. So those would be the first things. Number one, I'd be looking at acquiring practices. Now is the time. But if you're in the boat where you're in network, your profitability is no good, you don't exactly know what to do to fix it, I'm going to recommend something we call our independent practice blueprint consultation. I know that's a mouthful, but what we'll do is we'll take a look at where you are, right? Because if you're in that situation where you're the person doing 60 a month with 70% in network, or 70 a month or whatever, you're what we call the squeezed middle. You're the squeezed middle. You're being squeezed economically. So we'll look at where you're at and then take a look at what it would take to move your practice into that tier 1 independent practice, because that's where you're going to want to be over the next 5-10 years. That's where all the opportunity is. And I would look, a lot of people depend on you, not just you obviously depend on yourself, but your family depends on you, your staff depends on you, your patients depend on you. So you want to make sure that you're in the best position possible to navigate the changes over the next 5-10 years. And like I said, dental therapists may be an option for you as things grow, or if availability stays low, and they can always be a force multiplier in that independent practice. It doesn't have to be a situation where they have to end up in one of these DSO offices, but I could definitely see that coming down the road. Anyway, kind of an oddball episode. It was sort of an appendage from last week's episode. It was part of the big briefing, and I didn't even make it into the owners conference just because I went, this is way, with the amount of time I had, it was way out there. I would never make it, but I thought it was something that we should talk about because it's something I think that you should be aware of. A lot of us, laws get made, things get proposed, especially when it concerns you or your profession or your life. You should be aware of them. I'm telling you to watch the news or anything like that, but you can at least be aware of what's being covered in your latest legislative session, because there's a chance there's legislation for this in your state. And if I saw that, I wouldn't be against it necessarily. I mean, the Florida Dental Association was the only opposition to it in Florida, right? So I'm kind of neutral on it, right? But here's the one thing I will tell you is, if I saw that happening in my state, the first question I would have is why? Why? Because if that tells me that, if I see it, that tells me we have a shortage, and that's something that, as a doctor, if I was a practice owner, that's something, if I were a doctor, I would want to know about, because that's something that I would want to take advantage of to see if I could get more care to more people. You see, obviously, if I was concerned about quality of care or whatnot, then I'd have to take action. But it's just something I want to be aware of because it affects me, my profession, and my future. Anyway, like I said, oddball episode. I do hope that it helps. Don't forget to check out that independent practice blueprint. I've got a link to it on the episode webpage. Otherwise, folks, that's all I have for you this week. If you want to find out more about MGE, you can find us online at mgeonline.com or call us at 800-640-1140. Folks, have a great week, and we'll see you at the next episode.